Good morning, everyone. We're going to give it about 2 more minutes to give others an opportunity to join before we get started. Okay, well, good morning, everyone. I'm Sarah Ledwick. I am a public health nurse with the Sutter County Health Department, and I'm the director for our maternal child adolescent health and child health and disability prevention programs. I'm happy to be here today to introduce our workshop on trauma-informed healthcare. Today's virtual workshop is made possible by the California Department of Healthcare Services and the California Surgeon General's Office with funds as an ACEs Aware grantee. The goal of today's workshop is to provide you with an overview of information on trauma and trauma-informed care to enhance your understanding of the role trauma plays in the lives of the individuals and families you serve, and support you in adopting trauma-informed approaches in your delivery of healthcare services to promote healing for trauma survivors. The incredible Becky Haas is with us today to inform and enhance our trauma-informed practices. Increased understanding is the key to creating a trauma-informed community where experiences are recognized and treated with dignity. Becky Haas is an international advocate and facilitator using a trauma-informed approach and the Adverse Childhood Experiences Study. Becky is certified by the SAMHSA Gains Center. We are happy Becky is here with us. Before I turn today's workshop over to Becky, we must recognize that trauma-informed information can bring up emotions and possible emotional triggers, as the majority of people have been exposed to trauma, and we want to be mindful that some of this information may be troubling. Please feel free to take a break, breathe deeply when necessary, and know that a recording of this workshop can be found at setterkids.org in the ACEs Aware Healthcare Provider tab. So feel free to come back to the workshop when you are ready, and know that a video of this workshop will be available for you. A few housekeeping items. All participants will be muted during the workshop. Becky will take time at the end of the workshop for addressing questions, so please use the chat function to add your question, or feel free to raise your hand when the Q&A portion occurs. Also, if you requested to receive CMEs or CEUs when you registered this training, you should have received an email with instructions on how to receive your continuing education credits. Please remember to sign in and out of the training using the chat box, so we have a record of the time you attended. Thank you all for being here. We look forward to this journey of growth together. Now it is my honor to turn this wonderful morning over to Becky.
Okay, thank you, Sarah, and thank you everyone for joining, and for Julie and her assistants. So we're going to jump right in. This is a full 2-hour training, so we'll crunch it in a few minutes so we can finish for a few questions at the end. And just to kind of echo Sarah's message there, whenever training about the content of trauma, we like to just really reinforce do no harm. Some of the conversations, some of the stories, I'm a storyteller, maybe some of the videos, they might talk about our stories. And so if at any point during the training you just need to take a break, get a breath, a drink of water, feel free to do so. So today's training is geared with helping those in the health profession of any kind, whether it's a public health, community clinic, whatever your role may be, to understand that we have a large number of trauma survivors, not only that we serve in our client base, patient base, but also even among our workforce. So we're going to cover some of the basics, and then we're going to talk about looking through the lens of trauma-informed care as we go about health services. So I'm hopeful today that you're going to learn, gain some new understanding, as well as some new tools as we go. All right, so thanks for joining. A couple of slides, we're going to ask you to participate in the chat, and Sarah's going to help me to moderate that. So that'll kind of help you to really to stay tuned in. So the first module, we're going to help have a shared understanding of what is trauma, how to identify trauma. Trauma is like the wind. You don't really see the wind. What you do is you see the effects of the wind. And so that's, what we want to talk about, some behaviors that can help us to identify trauma. And then we want to see how the trauma actually derails brain development. And we'll talk about that. So some of the main takeaways from today's presentation is to help us to see that we want to shift our thinking. And I know California, under the leadership of your great Surgeon General, Nadine Burke-Harris, is really creating a state that's a leader in this conversation. But when you understand trauma-informed care, it shifts the thinking. Instead of what's wrong with you, that may be why someone's coming into your clinic or you're having them in your office, is what happened to you. And then we're going to talk about how that symptoms that present, that people come forth, maybe mental health, drug addiction, alcohol abuse, tobacco, many of the things that public health and health providers address could actually be adaptations to trauma. And then the good news about understanding trauma and resilience and the ACEs study is that healing does happen in healthy relationships and healthy community support, and that you don't have to be a therapist for your actions to be therapeutic. So we're going to start it off here with a quick little video by Brene Brown sharing the difference between empathy and sympathy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right, let's talk about that video. As many times as I see it, it's always such a great reminder that empathy is basically seeing things from someone else's side. It's staying out of judgment. A few years ago, I trained about 150 college-age students that come in the summer for an organization called Appalachian Service Projects, and they go all throughout rural Appalachia, and they do free home repairs that are paid for by donors and grants and things like that. And, when we were talking about this very topic, I was encouraging them that when you go into a home of someone that, is somewhat in ruin because of poverty or just the conditions they're living in, that we have no idea what brought that family, to that moment. And as I began to first learn about trauma-informed care several years ago while I was working for the police and very involved working with the jail population, I was so, it so impacted me to see how many families started out in a position with an addicted caregiver, incarcerated caregiver. And so professionals, we have to remind ourselves that we don't pick where we start in life. And so we want to always stay out of judgment and shaming and blaming in our communication. And empathy is basically recognizing emotions in other people and communicating this recognition. So when I was working for police, I oversaw the development of a first probation program of its kind in the state of Tennessee, which went on to become a state model. And I worked with felony offenders with addictions. It was a diversion when they had come out of jail. If they violated probation, the judge had this as a new resource to send them to. And it was 12 to 15 months long, 20 hours a week, basically an intensive outpatient type program. And one day I was in the program listening to the groups, and a lady was there whose charges were manufacturing meth, which are very serious charges. Trauma is not an excuse for drugs or crime, but it offers us an explanation. And this woman began to tell how her youngest memories of her mother as a child was her mother's a heroin addict her whole life. And that when her mother would shoot up with heroin, that she would get very sick and she'd be in the bathroom. And this little girl said, I would go in there with my mommy and pull her out of the toilet while my older sister's just screaming, let her drown, let her drown. And that day that impacted me in such a powerful way that when the group was over, I told the young woman, I said, I'm so sorry that this is your story. And a part of this program and a part of your treatment plan is counseling. And I want to encourage you to avail yourself to counseling while you're in this program, and that you should be able to resolve the fact that it wasn't your fault that you were born into a home where your mother was struggling with addiction. And the day that I said that, she smiled up a bit. And a few weeks later, I was over there and I saw her again, and she came over to me and handed me a little note. And when I went home that night, I remembered it was in my pocket, and I pulled it out and it said, thank you, Miss Becky, for treating me like a person. And, professionals, even though if she'd have failed a drug screen, absconded, I would have been in my role with police, I would have been responsible to file papers for a warrant for her arrest. But that day, just listening to her story of hardship, woman to woman, I just encouraged her to be able to take advantage of the counseling there and expressed a display of empathy. So again, this using a trauma-informed lens can help us to be therapeutic without being a therapist. All right, so what is trauma? We're going to go with the SAMHSA definition, which involves 3 E words. So trauma can be defined by an event, a series of events, or that are experienced by an individual that are physically or emotionally harmful or life-threatening, that can have lasting adverse effects, and can on the individual, they have the lasting adverse effects on an individual in several ways: mentally, physically, socially, emotional, or even their spiritual well-being. All right, that's kind of a mouthful. So let's break the E's down one at a time. So potential traumatic events, and again, we may see our own story in these columns. We see abuse in different forms, domestic violence, witnessing violence, institutional abuse, things like in a prison setting, and even at times in a hospital setting or a healthcare setting. people have experienced forms of abuse. Or then there's the chronic stressors of poverty, racism, community trauma, children living in a home with a family member with substance use disorder or incarcerated. Or then the types of events that could be characterized as loss, death, abandonment, neglect, separation, natural disasters. At the beginning of getting ready for this call, I was asking the leaders there how were the things with fires dying down. And we think about and watch in the news every year our friends in the state of California that navigate these difficult situations, which can be traumatic events. And then the second E is the experience of the trauma can be impacted by how did it happen? When did it happen? Where and how often? And when I was developing these trainings, when I was still working for police, I had some long conversations with some of the child crime investigators. And they told me that it's very seldom in the crimes they've investigated that involved a homicide of a child 2 years old and under, that it's very seldom that a child is abused or neglected at the hands of a total stranger. That more often it's through a known caregiver. So when the violence and the victimization is coming through a known caregiver, those are the types of things that it can increase the experience of the event that occurs. So it's not the individual's experience that is necessarily traumatizing, but it's some of these other factors as well. And then we want to look at the effects of trauma. And so the effect of trauma can be something become very normal, a normal response, which to you and I, when we hear some of the stories that I'm sure that you've heard in your career, it's very abnormal. So another day I was back in the prison diversion program, the day reporting center, and the same young woman, as she was going through her MRT program, she was talking about one time her sister was 8, she was 6, and the mother had a brand new 4-week-old baby sister. And the mother left them for a couple of weeks, and they had no cell phone, had no idea where their mother was, had no idea how long she'd be gone, no way to get a hold of her. And these little girls are navigating the care of this 4-week-old baby sister. And she began to say in the group that day about holding a mirror under the baby's nose ever so often to see if breath was coming out of the baby. And miraculously, they kept this little baby alive for 2 weeks. And then they finally reached out to the grandparents who came and got them. And I was so shocked that day hearing her tell that. And I said to her, why didn't you tell anyone at school what was happening? Why didn't you reach out for help? And she said, oh, we thought everybody whose mom has parties and all, that they're locked in their room at night. And so to her, what seemed to me a very abnormal situation, to her navigating it had become very normal. So survival mode is supposed to be a phase that at times will save our life, but it's not meant to be how you live. And professionals, many of the trauma survivors that we serve in our programming, they are literally living in survival mode. Even if they reach maybe a better place in life, sometimes because of that trauma that's happened in their life, they're walking through life in survival mode. So how do we identify trauma? This is a really important slide. Really, I maybe should break it into 4 different slides because it's a lot of information. And the slides will be available. I'll make them available to the leaders here to share if you'd like a copy. But a couple summers ago, I was training 200 regional school nurses. And when I got to this slide, they're all shaking their head up and down, because when you look in the first column under physical, every school nurse knows they're going to have the frequent flyers every year with the headaches, with the tummy aches, and certainly that may be a headache. It may be a tummy ache, but it may be that a child is witnessing violence in the home. Statistically, it takes 7 acts of violence before a victim will reach out to go to a shelter or to reach out to a family justice center. So even though victims may call police from time to time, they stay in a situation that can be very unsettling to children. And so there are a lot of children growing up where there's unreported violence, and that could impact some of these types of physical reactions. And then emotional. No child of the age of 8, as I've heard in our school system, having ulcers. That's not about things going on at school generally, but it's about navigating a very difficult life away from school. And then there are behavioral identifiers, things like substance abuse, alcohol abuse, eating disorders, anger related, isolation, and then cognitive, the inability to concentrate, memory lapses. Earlier this year, the ETSU College of Nursing, they have a grant they created a certification program for sexual assault nurses. In our rural community, it was 115 miles round trip to find the nearest sane nurse until they started that program. And one of the things they found in just conversations regionally was that police officers in a high percent decided or had perceptions that sexual assault reporting is false reporting. And the reason they based that is because often a sexual assault report will be a delayed report. But FBI data totally contradicts that in the fact that sexual assault reports are less than 5% of the time false reports. And so that's why I'm also training police officers. I'm going to be training them there in the Yuba City Police coming up later today. Because when officers see this slide and understand that the inability to concentrate, memory lapses, increased helplessness, distraction, intrusive thoughts, all of those things really should further strengthen the fact that someone is a trauma survivor instead of the on-ramp to the justice system feeling like maybe someone is not telling the truth. So it's very important that all of us in our professional roles understand how to identify trauma. All right, so let's think just a minute about the brain development. So the brain has a bottom-up organization. The bottom controls the most simple functions, such as the vital signs, respiration, heart rate, blood pressure. And then the top area, which is colored red and yellow there in that slide, those are more complex functions, thinking, regulating, problem solving. That's the cortex area. And then the other area of the brain that we discuss in this training on trauma-informed care is the amygdala. And if you look at that slide, a little tiny gland at the base of the brain is called the amygdala. And so the amygdala could be referred to as the fire alarm. So when we're in the woods camping and all of a sudden there's a holler that a bear is now on the campground, then what's going to happen is generally our thinking brain is going to shut down. And without our having really much control, we're going to shift gears to go to operate from our amygdala. And that's where why it becomes hard to think in a time of crisis. So this is quite an eye-opener of a slide. So when I was working for the police and began to train professionals in our community, in 2018, I was very surprised to learn that we had created a model that was nationally recognized by some at SAMHSA. And they came and we had a forum and 2 governors' wives came and people from 20 states. And we told our story about creating a trauma-informed community. And I was quickly recruited to our largest health system, which covers 3 states, 22 hospitals throughout rural Appalachia. And they sent me to Nashville in February of 2019 to speak to the Senate Health Committee about the subject of trauma. And, you always like those presentations when you only have 7 minutes, and that's about what I had. And I thought, what could be the most compelling evidence I could bring to our legislators to understand why we need to address trauma, particularly in children. And so this is one of the slides I chose. So typical brain development has a tiny little bit upside down, a tiny upside down pyramid, a tiny little bit of the survival mechanism that's used and activated. But because of the caring and nurturing of caregivers, when a little child falls down or scrapes their knee or has a boo-boo or whatever it might be called in your family, there's caring adults that soothe that child. And so you can see then by the size of the pyramid that then that child has a whole lot of the upper brain being developed. However, professionals, when someone is growing up in a household where there's mental illness, ongoing physical illness, where there's addiction, where there's alcoholism, where there's neglect, where there's abuse, where there's extreme poverty. In my own town, every year the school board would say there's between 300 and 400 kids in the public school system that are classified as homeless. Now, that doesn't mean those kids are sleeping in a car or under a bridge, but it means when they leave school every single day that the teachers have no permanent address on file to that child. And professionals, what we see is that type of instability and household dysfunction is actually creating the brain in the upside down fashion, where the most part of the brain that the child is using in those early formative years is the survival mechanism. And so that, to me, right there is something that we really need to take to heart. All right, we're going to show a quick little video here that's kind of in a cartoon fashion that explains some things about how the brain is built.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the earliest years provides a good base for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious, ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
All right, let's talk about that video for just a minute. So basically they talked about in brains being developed for a child, that a process called serve and return, and they illustrated it there like a tennis match where a baby coos and passes the ball over to the caregiver, and the caregiver hits it back. And so the way that a child would serve would be to pick up a toy and carry it over to a caregiver. And the way the caregiver would return, it would be to notice a toy or name the toy or make the noise of the toy. And as we begin to train the community here in Northeast Tennessee, one of the things that I never could imagine that started to happen was when we began to put the trauma-informed lens on professionals, police and healthcare and teachers. Our librarians started slipping into the group. And we've had some librarians regionally that turned preschool reading group into serve and return, because now they understand when kids are growing up, and the Center for Disease Control says the #1 form of neglect or abuse of children is child neglect, where the children are just not getting that attention from caregivers. And that could be any socioeconomic group. And so they started creating serve and return reading groups. So in this video, it emphasized the importance of that serve and return. And the video called Serve and Return Building Bricks, okay? So then when the bricks are built, then the video went on to explain you could build buildings. And one of the buildings, which is emotional regulation, they named it air traffic control. So now we see why kids are coming into preschool, into Head Start, into school, and just having emotional meltdowns because they've not had the serve and return from caregivers that built the bricks, and then they were not able to then construct the air traffic control or the emotional regulation. Okay, the next two slides come from the Tennessee Building Strong Brain Network, which I became a trainer in 2017 in their first cohort, as Tennessee as a state began to work to become trauma informed. Now, the thing I want to point out to you in this slide is notice a little girl in the pink blouse, okay? She's in every one of the scenarios, all right? So the first one is labeled positive stress. So notice that the boulders there or the platform there is labeled meeting new people. So all of our lives have short bursts of stressful events, maybe a job interview or public speaking. Many people tell me that public speaking just turns them into a bowl of gravy, you know, that they just would rather do anything than have to get up and lead a team meeting or speak in public. But we know that by crossing through some of those positive, stressful events, that we actually then sometimes gain new courage and new skills to go on and take new challenges. So a bit of stress can be actually positive. But notice in the middle, now it's labeled tolerable stress. And notice the size of the boulder, how much bigger it is. And it's labeled death in the family. Now, professionals, this boulder would not be scalable to this little girl on her own. But notice what she has at the top of the boulder. She has a support system. And so early on there in the training, I mentioned that though this is a message about trauma and hard places in life, but the good news is that we can navigate these and we can become more resilient as individuals and communities because of having healthy support. But then notice the far right. This is labeled toxic stress, and these boulders are impassable, and she has no support system. And if you would read the labels on the boulders, abuse, neglect, parental addiction, they even hint at the idea that the stress is coming from within her own home. All right. And then if we get real scientific and put these types of stress on a little graph, We notice that positive stress, the job interview, the public speaking, it can peak up there and be very stressful, but it goes down over time and becomes fully manageable. But then we have the tolerable stress, the loss of a family member, maybe sudden loss of a job, or a divorce, or a loss of a family member through COVID-19 or some other illness. And that's very stressful. And we'll begin to navigate that stress with our support system. And then maybe we reach the parent's birthday or a first Father's Day or Mother's Day, and it'll peak back up. But notice again, that type of stress over time, it goes down and becomes a bit more manageable. But look at professionals' toxic stress. This is right here why I was recruited to come into healthcare, because when our amygdala is overactivated and we're living in constant, ongoing threats of stress, household instability, household dysfunction, our amygdala is releasing unhealthy amounts of cortisol into our bodies that now are recognized to be linked to certain types of cancer, COPD, diabetes, heart disease. So it's not healthy for us to live in toxic stress, okay? All right, we're going to have a little review here with a case study, and I want you to go into the chat and I want you to answer what type of stress each of these case studies you think would best be labeled, okay? So we had positive stress, we had tolerable, and we had toxic, all right? So the first one, your coworker has committed to make a presentation for the team on a new product. On the day of the presentation, the coworker is homesick, so the boss asks you to make it very last minute. I want you to go in the chat box and enter, is this an example of positive stress, tolerable, or toxic? See what you're, oh, good. All right, I see positive. Very good. All right, great job. All right, now let's look at the next case study. So a family member consists of a mother, a 2-year-old, and a 6-month-old infant. And they come into the health clinic where you learn they've been evicted from their apartment due to unpaid rent. And then you learn this is the second time this year this has happened. Now, go in the chat box. Is this an example of positive, tolerable, or toxic stress? Oh, you all are good. You all are very good. All right, toxic. Yes, that's right. That's right. Exactly. Toxic stress. And your brilliant Surgeon General, Dr. Nadine Burke-Harris, you know, in her TED Talk, if you've never seen it, I would encourage you to watch it. She talks about, as a pediatrician in San Francisco, when she began to learn about ACEs, that she likened it to lead poisoning. And she thought she could have her clinic be addressing, you know, lead poisoning, and she could become now, you know, renowned for helping patients be comfortable around lead poisoning and be aware of symptoms, or she could go to the house and find the source of the lead. And that's exactly what we're learning to do when it comes to helping families to get on their feet and reduce these sources of toxic stress. All right, the last one, let's go into the chat box as you did before. So one of your team members has recently lost their grandmother to COVID-19. Is this positive stress, toxic, or tolerable? Oh, tolerable. You all are doing so good. All right, very good. All right, thank you so much for your participation. So I see you understand there what the levels of stress are. All right, let's move forward. So this is a simple exercise. When I'm training groups in person, we always have fun with this one. It comes from Dr. Dan Siegel, the Whole Brain Workbook. And if you're in a clinic setting and you're working with families and you see that there's indication of possible ACE scores, this is a great thing that helps people to understand, particularly children, about what part of their brain is bringing about what type of activities. Think about chaos and calm. Think about those two words, chaos and calm. Calm is upstairs brain, chaos is downstairs. So what we do with our hand is, if you open your hand and wiggle your top 4 fingers, this is your cortex, your upper brain. And then your amygdala, you think about it like your thumb. So while you're in this training that today, your brain looks like this, like a fist, okay? And your cortex is listening, taking notes, maybe eating a bite of lunch or a snack, and your amygdala is all tucked in and quiet. But if while you're in that training, someone says, there's a bear in the building, the literature calls this flipping your lid. And remember earlier, I said that it's your thinking process is meant to shut down when your amygdala goes to work. And so this is flipping your lid. So now when I'm training teachers, and I've trained thousands of teachers and preschool workers, also many of them across the state of Tennessee, Mississippi, we're helping teachers to understand how a child's going to be behaving when they're upstairs and when they're downstairs, and what are some simple strategies that we can bring into our classroom setting that can move them like an elevator between the floors. And in healthcare, the same thing. Some things like deep breathing, just to help someone take a few deep breaths. That's going to help them to get regulated, come out of the downstairs and move into the upstairs. And we're going to talk a little bit more about that in a bit. Okay, so are these really problems coming into our clinic? Are these folks really just hard to get along with and just trying to make your day hard? Or are these adaptations to trauma? So the amygdala can only do 3 things, because if you feel your life is overwhelmed and threatened with danger, your system is made to do these 3 things to survive: fight, flight, or freeze. And then over on the right there, it gives a little bit of explanation for each, which is pretty self-explanatory, okay? So some of the factors that can increase the impact of trauma is how early did it happen in life? Was there blaming or shaming involved? And were being silenced or not believed, which we know many times the perpetrator, when someone is violated, particularly as a child, they're instructed and warned and intimidated fearfully. And the same is true with a victim of intimate violence, intimate relationship violence. Often they're threatened if you tell anyone about this. So those are factors that can increase the impact of the traumatic event, or that the perpetrator, again, is a trusted caregiver. So what does trauma look like? Well, I have many variations of this type of training, but this is my healthcare. So we put in there some slides that might depict what it may look like in a healthcare setting, where sometimes we have to talk about some hard news, maybe a hard diagnosis, maybe there's going to be some complicated treatment, or now particularly around COVID-19. It's very difficult. Family members can't even, we had a lady in our church that was on a ventilator 17 days, and her husband, thankfully she recovered fully, really quite miraculously. And her husband talked about how difficult it was not to be able to go back and to see her. And then we have, it can also look like disconnect or aggression. People, maybe their loved one has been in the hospital a long time. Maybe they're also navigating FMLA or childcare. And so, they begin to just be overwhelmed, and we can start to see disconnect or aggression. And then a bit more in our training, we're going to talk about protecting yourself from secondary trauma or vicarious trauma. So a trauma-informed approach care serves as a strategy to help healthcare agencies gain the awareness, the knowledge, and skills to better support individuals and ease patient management. This approach prompts us as service providers to think about the individual as a whole person, not just whatever they're presenting to your clinic for. If it's arthritis or a kidney infection or whatever, bruise or headaches or whatever, this trauma-informed lens, using the trauma-informed lens, just puts in our thoughts maybe that some of the things that they're coming into our medical services for are also have extenuating circumstances that can include trauma. And it necessitates then that the service provider approaches recipients from a perspective of empathy and compassion and reject ideologies of individual blame for life issues that might have been instead created by many factors. So this is some information that I really enjoy sharing in this presentation. So the historical view of medical training, whether you're a physician that's on here today, a nurse, physical therapy, public health, whatever your role is, behavioral health, but particularly in the medical sciences, that the training involves two things. One, the science of medicine, it's just how to treat the patients with diagnostics and pharmacy and physical therapy, rehabilitation. And then there's the art of medicine, how to take care of them. But a few years ago, some doctors at the Cooper Institute, they did a systematic review of over 1,000 case studies that dated back, I think, back into the 70s. It's a marvelous book. I am not involved in any way financially, but I have met Dr. Treziak and complimented him on this great work. But in the review that they did of compassion in healthcare, they found overwhelming evidence that when there's greater compassion shown in a healthcare setting, that it did two things. It helped patients to heal and to come into a better place of flourishing, and it helped to reduce provider burnout. And so what they actually found is there is an overlap between the science and the art of medicine, and where there is a convergence, where the art of medicine and the caring of people actually becomes a science. And so, like the lady that day in the prison reentry group, where I just said to her, I'm so sorry that that's your story. And so by just showing empathy and compassion, that's what these doctors showed, was that actually was scientific in showing creating greater healing environments. Okay, on our next module, we're going to begin to talk about the actual ACEs study, which, as you probably likely know, comes from California. And we're going to talk about the prevalence of trauma. All right, so in this module, we're going to talk about the ACEs study. I'm going to show you a little video here. Then we're going to see the role that trauma plays in patient health, and then talk about national statistics that really, it's pretty overwhelming, the prevalence of trauma. And then we see what are some, we'll begin to shift our attention to what is actually trauma-informed healthcare. All right, so this little video is about 5 minutes, and it's going to explain the Adverse Childhood Experiences study.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
All right, let's talk about what that video shared. So in the late 90s, 2 doctors, Vincent Felitti of Kaiser Permanente and Robert Anda of the Center for Disease Controls, they actually were doing research independently and learned about each other, and then came together and formulated what is the 10-question adverse childhood experiences study. And it was the 10 questions were scrolling there on the screen. 5 things: did you see this in your home before age 18? Or 5 things: did this happen to you? Things like, did you witness violence in your home? Did you have an addicted caregiver? Did you ever feel like no one would take you to the doctor if you needed it, or have food to eat, or place to stay? And what they found was that generally, if someone answered yes to 1, they would have an increased chance of having more. And the higher the ACE score, the more likelihood these same individuals were ones that were early age tobacco, teenage pregnancy, risky behaviors, and that then is leading to poor health. And so it was, quite really remarkable what was unearthed in this study. And so we see here in this little graphic that when ACEs are the foundation of life, which again, no one picks where they start in life. So when ACEs are the foundation of life, that is going to lead to toxic stress, derailed brain connections, which we just talked about a minute ago. And then that's going to interrupt our school success and going to lead to poor coping mechanisms like eating disorders and cutting and drug addiction, early age alcohol, teenage pregnancy, many of the things that really public health and local health community and hospitals are immersed in. And can you see why this is providing communities now literally around the world with an upstream approach to improving the health of a community? So when bad things happen and we don't have a healthy support system, many individuals then come into a place of unhealthy coping skills, which leads to poorer health and even early death. All right, so ACEs can have lasting adverse effects on the health in many different ways, which we see here on this slide with obesity, diabetes, suicide, behaviors with risky behaviors as coping skills, and then overall life potential. I never heard the phrase until I went for work for police, cradle to prison pipeline and school to prison pipeline. And we see now, we understand now because of the ACEs study, why individuals sometimes do not have the same potential moving forward. Now, again, this is a message of hope and inspiration that we can provide mentors. We can provide healthy support in our communities. We have a group locally that is doing some fantastic work through Park and Rec, of all places. They wrote a mentoring grant and they asked, put it in the newspaper, went on the news, and they have business people and individuals from houses of faith that have just agreed to mentor a child, and they match up these kids. Before COVID, I trained all the mentors, and they just meet with this child to provide healthy support, because we know now that that can turn a situation around. And we saw that in the ACEs study that it was found to have a graded dose response relationship, that the higher the ACEs, the more likelihood that they would have risk values of many of the things that are challenges in all of our communities. So imagine me in 2014 hearing about the ACEs study and hearing Dr. Folletti while I'm at the police department, while hearing him say at a conference in California. I seem to be referencing California a lot. We all learn a lot from California. I'm giving you a high five from Tennessee today, but I was in California at a Family Justice Center conference, and I heard Dr. Folletti say that if a man answers yes to 6 of these questions, he's 4,600 times 4,600% or 46 times more likely to be an IV drug user than a man that answers none of these things happen. And I just pulled up on my phone the American Heart Association. And I know from being in health plans, my family and I, that when our health plans years ago started having health classes and health organizations spend billions of dollars every year on educational programs. And I'm sure maybe many of you are involved in bringing smoking cessation education or teenage pregnancy, diabetes, nutrition. That may be some of your job descriptions. And I begin to see, looking up that day, the Heart Association talks about that 12% of a heart attack, it can be included if someone's not exercising, or the risk for heart attack can increase by 50% when you're a tobacco user. And I wondered, where was the education about ACEs as far as drug addiction? Because here I am in a program that the judges have told me, here's the criteria: people with felony offenses that violate probation, that have active addiction. And I heard no one talking about ACEs as a contributing factor. And that's what made me as a community member, decide this story needed to be told. And so really it becomes a viable upstream approach in our communities, that though ACEs may be fact, they don't have to be fate. What's predictable is preventable. And creating resilient organizations and communities is an upstream approach to mitigating the effects of ACEs. So let's talk about the prevalence for just a minute. So in the area of mental health, a history of childhood trauma predicts things like earlier first admissions to mental health, more frequent and longer hospital stays, more time in seclusion or restraint, greater likelihood of self-injury or suicide attempt, more medication use, and increased symptom severity. And then these are statistics from SAMHSA and the Center for Disease Controls. And it was so impactful for me as a grant writer and an educator my whole career, to see the numbers of how many people have in common the common denominator of childhood trauma. 65% of the substance abuse treatment clients report histories of childhood abuse. 75% of women in substance abuse treatment report histories of trauma. 92% of homeless mothers have severe trauma history. Some of you may work in clinics that serve homeless populations. I know from working for police and working in healthcare. And when I worked for police, I headed the homeless task force in our community, working right with the mayor and the city manager. And when I began to see that the population of those who are living homeless, according to the Journal of Public Health in 2013, said that homeless individuals have the highest sampling of ACE scores of any other population, I began to train the homeless services in our community to understand the role of trauma. And then what about the role of trauma and the prevalence in children? So we see that 75 or 71% of children are exposed to violence each year. 3 million children are maltreated or neglected. 3.5 million to 10 million witness violence against their mother. And the large gap there, that's due to the fact that there's a lot of unreported domestic violence. You know, professionals, now this is a graphic story, but the day that I knew I needed to train police officers is when I heard a 911 call of a 4-year-old watching their mother being beat with a ball bat. And I thought to myself that day, I thought it'd be sure nice if a police officer had a mental health worker with them when they came to that call. Because what that 4-year-old never took into consideration is that while they're saving their mother's life, out the door is going to go their father in handcuffs. And so I thought, by training police to be an intervention, to be able to say on scene to children, you did the right thing. This is not your fault. That police officer, though they're not a therapist, they're having a therapeutic benefit to that little child. And that's why I'm now training police. I'll be in Indiana next week training police. I just got back from Delaware, training Delaware State Police, because we can see that different types of professionals, just as you in healthcare, that maybe by showing empathy and compassion to some of the people that are in our systems that have experienced horrific trauma and hard places in life, that we can help their healing process. And then look at this: 1 in 4 girls, 1 in 6 boys sexually abused before adulthood. And a study of juvenile justice, almost every child in juvenile justice, 94% experienced trauma. So that brings us to something healthcare understands perfectly well, and that is universal precaution, that we need to, like putting the gloves on before we go in for an exam, or the safety and precautions we take with handling blood. Now we need to understand that most of the patients that we serve in our health settings, and many of our team members as well, are trauma survivors. So trauma informed in healthcare is a strategy, a mindset, an approach that encourages service providers to be aware of the recipient's psychological and emotional as well as their physical needs, to approach them from a perspective of empathy and not blame for life issues that may be a result of response to trauma, to treat service users as equal, valued human beings, and to acknowledge trauma and have an empathetic response if a service user wishes to open up about their experienced trauma. And so a metaphor that the state of Tennessee came up that I think is just so really appropriate, I think everybody gets it, is charging station. So when I was traveling recently, I went to bed, getting ready to go to bed. My phone was battery is on red, but I had remembered to pack my battery, my charger. And so I didn't lose a wink of sleep because I charged my phone overnight while I slept. But patients that are coming into our clinics, and sometimes some of our coworkers, think of it as coming in with our batteries drained. And so what are we doing as a service provider that's creating charging stations? Is it a welcoming reception desk? Is it kindness in our voice? And we're going to talk about strategies here as we move forward. But we want to kind of hold that image in our thinking about what are we doing in healthcare settings that can be a charging station as we serve our patients. All right, we're going to do a quick little learning checkup. So I want you to go into the chat and we're going to use answers true or false or T or F. As I read these statements, go into the chat and answer. Number one, from the ACEs study, there were no significant findings from the ACEs study. True or false? No significant findings. Oh, good. False. All right. Very good. All right. Number two, if you score an 8 on the ACEs survey, it's true or false. If you score an 8 on the ACEs survey, there's nothing at all that can be done to prevent the effects of this trauma. True or false? Oh, good. You all are on the ball in California there. Very good. Absolutely false. There is something we can do. Okay. All right. Number three, when bad things happen in their lives, people either choose healthy coping skills or unhealthy coping skills. True or false? When bad things happen, people either choose healthy coping skills or unhealthy. True or false? True. Very good. I would give you all scholarship. Okay. All right. Last one. And this is so important. And that's why I kind of want to do this little checkup here, that drug use can be an example of an unhealthy coping skill. True or false? Yep. All the way across California, about a 7-hour flight from where I live. And you know what, professionals? See, when I worked in the police department, I've lived in this community since the 70s. I actually have a brother who is homeless and a meth addict, had a family restaurant, was successful, went from being an alcoholic. And I know this is personal, but I guess maybe why I'm so passionate about this topic, I have skin in the game. And I understand, getting a call in the middle of the night when he's put $1,500 of cocaine up his nose and he's at the ER and burned the bridges of family members. And of my very closest friends, I don't have one of them whose life in some way has not been impacted by drug use. And when I worked for police, I was so astounded to learn that the world population, 5% of the world population is made up of the United States. However, 25% of the world's incarcerated population is made up of the United States. And I know, working for police, that about 70% of incarceration is due to drug use, because once people come into a lifestyle of drug addiction, there's going to be crime, a lifestyle of crime that generally is going to help sustain that. And I've seen that in my own family as well. And so, it's very rewarding today to be engaging with you and see that you now can recognize that drug use is an example of an unhealthy coping skill. All right, let's move on to our next module. And we're going to talk about principles of using a trauma-informed approach. All right, so unlike other trainings that I've ever delivered in my career, this training, I think one of the things that helped Johnson City in Northeast Tennessee be recognized by SAMHSA as a national leader is that when we gave trainings, we kept them simple, we made them urgent, and we delivered them in a fashion that there's an expectation to do something with it. And that's what we're going to talk about now as we come down the home stretch. And so in this module, we're going to talk about why trauma-informed programs operate with a universal expectation that trauma has occurred. We're going to talk about the SAMHSA 4 R's of a trauma-informed program, organization, or system. And we're going to see why understanding trauma is important in healthcare. And then we're going to talk about each of the SAMHSA's key principles, 6 key principles, and give an example of them in a healthcare setting. So the 4 R's of a trauma-informed service. So number 1 is that we realize the widespread impact of trauma, and we understand the potential paths for recovery. Now, by attending this training today, that's something you could pretty much mark off, that you realize the widespread impact of trauma, and that the good news is there are paths for recovery. Number 2, we've learned in this training how to recognize signs and symptoms of trauma in our clients, in our families, our staff, and others involved. So we could check that off. But here's where we are right now. Number 3, how are we going to respond? How are we going to respond? Are we going to begin to integrate the knowledge? And I know from working with Sarah and Julie, Michelle, some of the others in Sutter County and leadership that reached out to me in Tennessee to help bring this training and professional development, that they want to begin to move the community to understanding what a factor trauma plays and childhood adversity plays into the life and the health of our community. And so how are we going to shift the culture? How are we going to move it beyond training? What are we going to begin to do to make it lasting in our organizations? And then lastly, what are we going to look at maybe that we could be doing that we are resist re-traumatizing? So having worked for police and healthcare, one day when I was working in healthcare, my office was the nicest office I'd ever had in any job. I've had offices that were in a closet in one job. Well, they did put some pictures on the wall, but they were short on space, so I went into a big closet. But this was in a very nice manager's, nurses' wings in one of the hospital. And one day as I'm getting ready to leave, the child life manager and some of her team, they're in tears, they're distressed. And I wondered if it meant that maybe, they'd lost a child that day. And I'm very compassionate. My husband says I'm the only M&M with no hard candy shell. I mean, I'm like wearing the t-shirts, need a hug. That's me. So I went up to the child life team and I said, what's the matter? Is everything okay? And they said, well, no. Said, we have a 9-year-old that came in today and in the emergency room and was saying they felt suicidal. And they said, we know this 9-year-old. She's in the emergency room pretty frequently. And we know there's trauma and dysfunction in the household of this little child's house. And so while she came in to the emergency room, giving voice of feeling suicidal, then they needed to transport her to another facility for a mental health evaluation. Now, I know from working for police that many times the ride across town to mental health and crisis oftentimes is police. However, in the general orders of police is if someone is a threat to themselves or to someone else, they have to be transported in handcuffs. So the child life team was so upset because this little 9-year-old left the hospital in the back of a squad car in handcuffs. And they told the little child, you didn't do anything. Please don't feel like this is your fault. You're not breaking the law. But, we've got to somewhere start to begin to look at maybe is anything in our process re-traumatizing, as I saw what happened that day. All right, so this little video is about 5 minutes, and it's one of my favorite. And it talks about in a healthcare setting, how can we become trauma informed?
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, so let's talk a minute about that little video. Make sure, okay, I'm unmuted. So in the video, she talks about 5 things that a healthcare organization could do to begin to use a trauma-informed approach. And one of them is to invest in training, which is why you're a part of that today, to raise awareness. But notice how that they talked about in the training, not just those that are in the healthcare role in a clinic or in a hospital, but also other people that might be involved. And so I had the real privilege when I worked in healthcare. Sorry, I got off my slides. When I worked in healthcare, of the 22 hospitals that the healthcare system had, in the 18 months I worked there, I had the privilege of training 2 hospitals, one 700 in its entirety in 6 weeks. And it was so rewarding to me to have a cardiologist sitting next to housekeeping and cafeteria. And you know why we did that? Because research shows who patients talk to more than anyone in an overnight hospital stay is housekeeping. And so we see that our housekeeping, when I was doing the training, you could just see housekeeping sit up like, yeah, man, I got an important role, because the kindness and the empathy that every person in your facility can show can be a part of the healing environment you create. And then she goes on to talking about that we can become healers and instead of just providers, that through the empathy and through the kindness, through our environment and the different things, that we can create settings, being aware that we're serving a high percentage of trauma survivors, and we can create greater environments of healing. So a few years ago, I was asked to speak for TBI, a Tennessee Bureau of Investigation, at the Senator Tommy Burke Victims Academy in Chattanooga. And what this is a week-long academy of victim advocates from across the state. And I was presenting on why we should create trauma-informed multidisciplinary teams. And I still do that presentation very frequently. And that's what I think, Michelle and Sarah, what some of the goal of the trainings that I'm a part of is creating there in Sutter County, trauma-informed, trauma-aware, multidisciplinary teams. And in that training, I talk about, if as a service provider, what if you had 70% of the people you served that they were non-English speaking? How would you as managers, or how would you as staff members, how would you approach that system to become effective in service delivery? Well, you would maybe hire bilingual staff or invest in technology that could help with translation. But what about if you had 70% of your clients and patients that came to see you? What if they're hearing impaired? How would you prepare for an effective service delivery? Well, you would invest in sign language. You would make sure maybe to put that in the job description of people as you hired, so that you can effectively deliver services to a hearing impaired population. But what if 70% of the population we serve are trauma survivors, and we've not known anything about trauma? And so many times people are coming in that with illnesses that are a result of trauma, or injuries a result of trauma, or behaviors are result of trauma. And so by shifting to understand about trauma-informed in healthcare, we can be a more effective service delivery model. And that's what that little video was portraying. All right. So some of the things about why I use a trauma-informed approach is we need to be aware of the life situations that might be contributing to the person's medical problems, domestic violence, human trafficking. Did you know that 80% of those that are in human trafficking, during the time they're in captivity, they have contact with medical personnel? They very seldom have contact with law enforcement, but 80% of them have contact with medical, but less than 5% of medical staff are ever trained to recognize or understand what behaviors someone may, or characteristics of someone may have of human trafficking. And then the health problems faced by people may be related to traumatic life experiences. And research has shown a decrease in doctor's visits in patients who receive empathy from healthcare providers when they become aware of trauma. And so trauma survivors are often very sensitive to situations that remind them of the people, places, or things involved in their traumatic events. These are triggers, and these triggers can cause a person to relive the trauma and view the setting organization as a source of distress rather than a place of healing and wellness. So let's think about our clinic. Let's think about a medical setting. That could be full of triggers, okay? Things like invasive procedures, removal of clothing, physical touch, power dynamics of a relationship, the gender of the healthcare provider, the personal questions that may be embarrassing or distressing, the vulnerable position for an exam, and the loss and lack of privacy. So a trauma-informed environment, that patients and family are treated as equal, valued humans, that staff and volunteers are aware of boundaries. Simple things are communicated, like touch, and turning off lights. Now, this is probably a little more information than you needed in this training, but a few months ago, I had to find a new OB. My OB retired, and my children are in their 30s, so I was kind of starting over with an OB. So this young doctor I went to visit, and on my visit, he begins to explain, now the lock on the door in this office, there's no lock on the door, and my nurse will be in here with me, and he's going through all this, and I go, time out, and he looks quite surprised at me, and I said, I wish I could video you. I said, you're doing a fabulous job of using a trauma-informed approach. And he smiled and he said, oh, you know anything about that? And I said, well, yeah, it's what I do as a career. And he said, well, I've really been reading a lot, and I'm using it now to teach residents in the medical school. And just his simple conversation of some of the things if I was a rape victim or a trauma survivor, that would have really brought me ease of mind in that exam room, just the very things that he was discussing that day. So I gave him an A+ in just by talking and communicating, and then using language that communicates empowerment and recovery. Punitive approaches, shaming techniques, and intrusive monitoring are avoided. I heard of a patient one time that was diagnosed with Parkinson, and she was in her 60s, and her husband, very supportive, but a bit of the quiet type. And so the family doctor, after her diagnosis of her Parkinson's was, brought to her, they referred her on to a neurology group. And so she and her husband went for an appointment to the neurologist. And basically her conversation for that day was to know what could be the best way to have the best quality of life while she's navigating out the rest of her life dealing with Parkinson's. And her husband, in this book that I read, said that the doctor said, well, you're going to come to this place in life, and eventually you may die by choking or falling. And after that visit, because of the rudeness of that provider, the husband of the wife said she plunged into depression just because of, just the matter of fact and, void of empathy that provider shared. Yes, they may have shared things that could have been true medical statements, but just the delivery of it, so that actions and words may be re-traumatizing as it was in that case. And that conflict with individuals who are trauma survivors is dealt with through negotiation. So remember our upstairs, downstairs brain, calm and chaos, okay? All right, so here's some examples of trauma-informed approach. So from the Children's Hospital of Philadelphia, I found a great one called DENF. And at the end of the slide deck, I have a link where you can go and learn more about this great program. And so those of you that are in medical and healthcare, in your general training, you learned about A, B, and C, life-saving steps of airway, breathing, and circulation. And so using a trauma-informed approach, we want to just add the letters D, E, and F. D standing for distress, E, emotional support, and F for family. So let's talk about distress for just a minute. Well, just a minute ago, I talked about lights going off, touch, changing, taking your clothes off. So we want to think about how can we make things that could be distressing, entering an IV or a port or something like that. What could we do possibly to someone who might be a trauma survivor to reduce the distress? And a lot of that could just be our simple calming communication. And number 2, E, emotional support, particularly now during COVID, when people are cut off because of just not allowing visitors into the hospital and all that. People need to be encouraged. When I worked in healthcare, I was really tickled one day to get to train all the chaplains from the 22 hospitals. And you never saw a group more fired up to hear about trauma-informed care and how much more valuable it made their role in providing emotional support. So often we would encourage nurses that if they observe patients that had no visitors, and now with COVID, they can't really have a lot, but using technology to FaceTime or, to have phone calls, that kind of thing. But then request a visit from a chaplain to just stop by and be a friendly face, because we know emotional support promotes healing. And then lastly, family. Sometimes think about our family members are overwhelmed with the trauma of their loved one's disease. They're trying to get the bills paid, keep a job, be on their job, take care of kids, and juggling a lot of balls. And so as you think about communication with family, don't feel impatient if you have to repeat things, or make sure that it's written down, or do reflective listening where you say something and ask them to repeat it back to you, because D, E, and F is going to help create a trauma-informed health setting. All right, and then this is an amazing study. In the book Compassionomics that I referred to earlier, they cited one of the studies that they reviewed, or well, several variations of it, was that in 1984, a study was conducted. And if any of you are on there old enough as me, you remember the audio tape recorders. When we first got married in the 80s, we were given as a wedding gift an alarm clock that had a cassette recorder, and we would go to bed at night listening to our little cassette recordings of music. And so now who would ever think you'd hear it all on your phone? But in 84, they took around tape recorders to doctors' offices. And here's only one thing they wanted to see. How long did doctors, the providers, listen to their patients? And in that study, they found 77% of the time, physicians interrupted the patients within 17 seconds of their opening statements. And this was so alarming that medical schools began to add communication skills and techniques to the curriculum to begin to address this issue. So 15 years later, a study was conducted and reported in the Journal of American Medical Association, and there was a bit of relief to find now that providers were listening 22 seconds before interrupting a patient. And in the second study, what I really like, and why I put this in my training for healthcare, is that the second study showed that patients felt they were compassionately listened to if a provider listened to them only 29 seconds. Now, if we were in person and we had time for a little role playing today, I would ask you to break into groups and talk to people and just time 29 seconds. Folks, it doesn't take that long for someone to feel compassionately heard. However, and sadly, in 2018, this study was repeated by the Mayo Clinic, and they clocked the time of first interruption of patients at 11 seconds. So what are we saying in sharing this information? That one of the things we can do in increasing empathy in our healthcare settings is thinking about those valuable 29 seconds. And emotional support matters. In a 2010 Brigham Young University study of 148 different studies they analyzed that involved over 300,000 patients over all kind of varieties of health conditions, they found that having meaningful relationships was associated with 50% higher odds of survival. And this is one I really love. This came from Vanderbilt's Children's Hospital. I'm always scouring and reading and looking for projects and programs that people are so innovative in creating. So the nurses there at the Children's Hospital realized that while they're wearing masks, that this is a bit unsettling to little children. So they created the Button Project, and they simply, with probably less than $2, have their lovely faces on a full button that they wear on their uniform. So now while they're treating the child, the child's able to see what this professional looks like with their mask off, but yet the safety of the mask is being still provided. And then for hospitals or maybe large centers, there's the Schwartz rounds, which are compassion rounds for the caregivers. I mean, not just the caregivers, but for the providers. And this is a program that's now coming more and more, gaining traction in hundreds of hospitals across the United States, where the providers come together once a month and they're able to process the stress of the job. You know, I know locally, one of our ER docs, his mother-in-law had a stroke, and now he and his ER that he's leading that night now has his mother-in-law coming in as a patient. You know, healthcare is hard enough, but now when it begins to touch home, we need to find charging stations for the healthcare providers. And that's exactly what Schwartz rounds are. And they've seen over the years that Schwartz rounds, when they are involved in a hospital, it actually improves the teamwork, interdisciplinary communication, appreciation for the roles and contributions of colleagues, decreased feelings of stress and isolation, more openness to giving and receiving in support, increased insight into the social, emotional aspects of patient care, increased feelings of compassion towards patients, and readiness to respond to our patients and their family needs. And then we want to think about the Medicaid population. Some of this, it's a small group, but it's a costly percentage of individuals who are the frequent flyers into our ER, including homelessness and those who are socially isolated, that these individuals have an exorbitant number of ER visits per year. And so healthcare organizations, a few that I've known and done some professional development for, they're providing deeper levels of case management for when someone comes in on a frequent basis. And the case manager is maybe learning that this is a veteran who's struggling with addiction. And now because of addiction, they're homeless, and yet they have an income, but yet they've fallen prey to predatory lending. And so this case manager is able to help establish a budget and get them into some sort of stable housing, and then begin to help them access the type of medical care they need. So it's a win-win for healthcare as well as for the individual. All right, we're going to wrap it up here in just a few minutes by talking quickly about the SAMHSA 6 pillars for creating a trauma-informed approach. So each one, I'm going to give a definition and an example. So number one is safety. So we want to make sure that our provider services are brought about in a setting that is safe. Our exam rooms, our hallways, our lobbies, that we're doing things. You know, I'm working with a group now training about telehealth. And in my training, I talk about thinking about telehealth like a visit. So when someone comes on the call, to just begin the call by saying, you know, we're so glad that we could have this time to visit today. And is this still a convenient time? Because stop and think about it. If a parent is got the computer maybe in the middle of the room, and now all of a sudden children are out of school doing a hybrid method, well, now do you think maybe some of the things they may want to discuss, could that be discussed in front of children? And so we want to think about, are we creating a sense of safety when we begin to engage with our patients? And we also want to think about the safety for ourselves as the provider. So what could safety look like? Well, this sign didn't come from a hospital. Maybe there's one out there, but I found this sign in a Walmart. Because what is Walmart doing? And you know where in a Walmart the sign is? It's a customer service. I mean, you're like close to sainthood if you work in customer service at Walmart. You've got to return, accept anything back for return. And yet they're saying happy to help. So we want to create a welcoming environment. We're consistent and predictable. We're non-shaming, we're non-blaming, we're non-violent, and it's respectful of privacy and confidentiality, clear explanations of what is happening and why. All right, number 2 of the 6 pillars is trustworthiness and transparency. In this step, we want to provide relationship-based care. You know, I love it when people pronounce my name correctly. My maiden name was Daniel. And no one ever mispronounced that. But for 37 years, I've been Haas, and I have spelled Haas more times than I care to count. And I'm always happy when I'm back to a bank or back to when my boys were little, the teacher. And it was just nice that someone took the trouble to pay attention to a pronunciation of a name, and sometimes to call someone by a first name. You know, professionals, it really doesn't take a lot to use a trauma-informed lens, and using relationship-based care can help. Showing dignity, showing respect, validation, listening, being present in the moment. These are all foundations for healing. And so some things that we could use as far as personal statements of empathy when there's disclosures of personal trauma, just simple statements like, I'm sorry that happened to you. What happened was not your fault. Thank you for trusting me by sharing your story. And you're not to blame for what happened. And look at that. Those are 4 simple sentences. I don't really remember a lot about English and about diaphragm, taking sentences apart. But these are simple. They're not complex sentences. But professionals, remember when we started, I said you could learn to be therapeutic without being a therapist. These 4 statements can be tremendously therapeutic for a trauma survivor. All right, number 3 is peer support. SAMHSA defines peer support as a flexible approach to building mutual healing relationships among equals based on core values and principles. They're voluntary, non-judgmental, respectful, and reciprocal and empathetic. Immediately, you think about programs like AA, NA, Al-Anon, domestic violence. All of these have very successful peer support type programs. And so what are some things in healthcare? Well, if a family member is dealing with a certain disease or illness or injury, or have a child with special needs, maybe there's a support group available that we can refer them to attend, or maybe create space where families can interact. For instance, when my first grandchild was born 5 years ago, this was before COVID, and I'm the granny that was up in the waiting room all night long. I wasn't going anywhere till that baby came, and my husband with me. And there were other families there. One family in particular I chatted with, and the grandparents were the same as us. It was a first grandchild. And several hours into our waiting, here came medical people in and had the family huddled in the corner. And when the medical left, I noticed some of the family members were crying, and certainly I was concerned. They left the waiting room, and I sure hoped that everything was okay with the mama and the baby. And the next day, I was so relieved to see the new grandparents smiling and back up in the waiting room. And I said, how's your little mama and how's the baby? And they said, oh, everything is fine, that they had to have they ran into some complications and had to have a C-section. And so what is happening? We're kind of got an organic support group sometimes going on in our waiting rooms, okay? And I can't really brag enough on this group, a St. Jude's Research Clinic, that I had the privilege of training the team members. And just to save time, I can't go into all the things they began to do by wearing a trauma-informed lens. But before COVID, and I left healthcare to start my consulting work, the director and I had lunch, and she told me that they had 5 children that were the same age they'd been treating for childhood cancer for 2 years. And these children now were all in remission, in a healthy place, and all of them were going to start kindergarten in August. And she told me that all the team, being trauma-informed, realized that these were little children that had never been to daycare, never been to preschool, and now they're headed into kindergarten. And so this group, they decided they needed a life skills class. So they got the parents together and asked permission on a given day to bring the children in. And so this group, they put together a life skill to prepare these little children to go to school. And they took the children down the hall and introduced them in different offices, showed them how to line up, raise your hands, took them into the cafeteria and showed them how to get food on a tray and place their order, open milk cartons. Professionals, would you ever expect that to come from a cancer research clinic. But see, when we begin to use a trauma-informed approach, we think about the whole individual and not just the medical situation that brings them to our office. And then we want to pause just a minute and talk about trauma in your life and when we're talking about peer support. So vicarious trauma, according to Dr. Riemann, is the expectation that we can be immersed in suffering and loss daily and not be touched by it. That's as unrealistic as expecting to walk through water without getting wet. So some ways that you can protect yourself as a healthcare worker from vicarious trauma: talk to colleagues and allow others to talk to you, and to realize processing the stress of your job is not a character weakness. Take breaks throughout the day. I encourage professionals, sometimes when you don't have a lot of breaks, do something as simple as fingertip push-ups or wall push-ups. Did you know 80% of your stimulation comes through your eyes? What if you can find a place and just sit a minute and just do finger push-ups and close your eyes? You'd be amazed at how much that creates a sense of wellness in you. And things like, if you need to seek out a group, if there's a Schwartz round in your healthcare system, or just maybe a group. Some hospitals are starting Zen rooms or yoga rooms, or a room with some candles and just with soft lighting and music where professionals can go and recharge their batteries. But you need to have your own safety plan. And one little simple thing is you can download a free app from the App Store called the Provider Resilience, and it'll have some stretching and exercises on there. But one of the reasons that I recommend it, if for anyone in the compassion profession, is that it has the professional quality of life scale on it. And it's just simple to use. You can do it every 20 days. It's about 30 questions. You just answer yes, no, and it grades it immediately. And it grades 3 things: professional satisfaction, compassion fatigue, and secondary trauma. And it'll help you to see how you're handling the stress of the job. Here's a couple of screenshots of what that app looks like, okay? All right, number 4, collaboration and mutuality. One of the pillars from SAMHSA in creating a trauma-informed environment is we want to find ways to partner and level the power differentials between the staff and the patients. In other words, we want to think about that medical areas can be a high risk for perceived power differentials. So are we allowing those patients that 29 seconds to talk about things? You know, in my own life, one time my mother had triple bypass, and she was about 6 weeks out. I stayed with her for a month while she was recovering from that, and because my father's deceased. And one night I had to take her to the ER. She was screaming in pain with the back of her neck. And after going in the ER and some x-rays and all, it was determined that she had a herniated disc. And so the doctor there gave her real mega doses of Motrin. And I kind of pumped the brakes there and told the doctor, had he seen her whole file, that she was recently gone through heart surgery, that she was taking a blood thinner, she was taking baby aspirin, and she had enrolled in a medical study, which either was a new blood thinner or a placebo, because it was a blinded study, so we didn't know. But mother was not going to be talked out of being in that study because she got a free gas card. And I mentioned all this in the emergency room to the doctor, and he assured me that she would be okay. Well, after a few weeks of those mega doses of the Motrin, one day she passed out and was bleeding out and had to go into ICU for several days receiving blood transfusions. Now, my point in saying that is, I'm a family member, and I'm just kind of cautioning the doctor all this other information. And I really was reluctant to do it that day because I don't have a medical degree, but I do know my mother. And so sometimes in collaboration with our patients, we are going to find some better outcomes. Number 5, empowerment, voice, and choice. And that as we realize that many of those coming into our health settings are trauma survivors, victims of violence, victims of coming into drug addiction, risky behaviors for coping, that we have to have a belief in resilience. And I tell this story every time I talk about this point, and that comes from a woman named Joyce Meyer. You may have heard of her. Joyce is a trauma survivor. Her father, a violent alcoholic, raped her over 200 times from the age of 9 to the age of 18. And her mother knew all along it was happening, but she wouldn't stop it because of fear of her husband herself. And Joyce tells her, for Joyce, charging station is definitely her faith. And Joyce tells this story in some of her talks that I really like. It's a made up story, but it really illustrates this point. There was a farmer who had a donkey, and the farmer and the donkey worked together year after year out in the fields and bringing in the crops and just a team. And in the fall, bringing in the harvest. And after many years, the farmer prospered to a place that he really didn't need the donkey because he bought a tractor. So he put the donkey in the back of the field, and pretty good retirement by donkey standards. And one day the farmer went to the barn to get the tractor, and he noticed he didn't see the donkey anywhere. And so he decided to find the donkey before he started the work that day. And as he walked through the fields, he found more concerning, very distressing noise, like an animal was hurt. And lo and behold, he found that the donkey had fallen down into a well shaft that was dried out. So while the farmer's standing up, looking 40 feet down, there's a scared face of the donkey on the bottom of the well. So the farmer's thinking, I don't know how I could rescue that donkey. And, he served me well, and I have my tractor now. I don't really need him. So the farmer went to the barn and got a shovel and brought the shovel back and stood there at the top of the hole. And the donkey's thinking, oh, good, here's help. He's going to rescue me. He's my friend. However, to the dismay of the donkey, the farmer began to scoop the dirt and throw it down, scoop the dirt and throw it down. And the donkey realized that his friend, the farmer, now is trying to bury him alive. And so after several shovelfuls of dirt fell on his back, the donkey got this little idea that every time the dirt fell, to shake it off and stomp it down, to shake it off and stomp it down. And professionals, sometimes what brings someone into your clinic is the dirt in life. And we have to build organizations that promote resiliency and empowerment and help individuals to shake out the dirt of joblessness, shake out the dirt of addiction, shake out the dirt of abuse and domestic, and to be able to walk into a life using some of the things that you're able to offer to help connect to those next steps. And then lastly, the 6th pillar is cultural, historical, and gender issues. We need to move past every type of bias. And it's not a matter of trying to find who we need to invite to the table now. No, we need to create whole new types of settings that are totally inclusive of every type of cultural connections and cultural respect. It's not a matter of understanding in detail every culture in the community. I'm doing work right now at the university in Lithuania. If you Google on your phone or computer, what world country leads by death of suicide, you will find it's the little country of Lithuania. In 2013, 1 of every 3 individuals in Lithuania died by suicide. And this group of university students, they've written a grant with the Red Cross, and probably next spring I'll be going there. But I've been training them throughout this year because on recognizing the role of trauma. And I know very little about Lithuanian culture, but did you know what we can begin to do to help trauma survivors is we can show great respect for different cultures that are represented in accessing our healthcare settings. So trauma-informed services focus on an understanding of the whole individual and the context of their life. And it's infused with the knowledge about the roles that violence and victimization may play in the lives of survivors. They're designed to minimize the possibility of victimization and re-victimization. Their services are hospitable and engaging and designed to facilitate recovery, growth, resilience, and healing, and are respectful of a survivor's choices and control over his or her recovery. And there are training sources and my contact information. And we just have a few minutes, but I am going to yield the floor back to Sarah. And I just want to thank each one of you for the work that you do in your community and for attending today.
Thank you so much, Becky. We just really appreciate all of the wisdom that you shared and the concrete examples of providing healthcare through a trauma-informed lens. So as you said, we just have a few minutes left, so I want to open it up for questions. You can use the chat or raise your hand if you have a question or even a comment for Becky, and I will be looking at the participant list and the chat box, keeping an eye on it. Just I see in the chat a lot of thank yous and what an amazing presentation it was. Are there any questions or comments for Becky? I know for me, I've never seen that app before, the Provider Resilience app, and I really appreciate you sharing that. That was a new resource for me.
You're welcome. I recommend it. Last week, I was training EMS workers at the College of Medicine and, sharing that with them because it's just simple and free and no one has to know. You just check every 20 days, see how you're doing.
Yeah. Well, I don't see any questions, just again, a lot of thank yous and what an amazing presentation it was. So I think with that, I just want to remind those that did register for CEUs or CMEs to please make sure to put your checkout time in the chat box. And you should have received an email with the post evaluation that needs to be completed and can be emailed back to me. Again, thank you so much, Becky. Always find your presentation so inspirational, and I love the videos that you have to share.
Well, thank you, Sarah. We'll see you again soon.
Take care. Bye-bye.
Bye-bye.